Insights from the world's best medical minds. You are watching therightdoctors.com.
Good evening, colleagues. I am happy to meet you all digitally through the Right Doctors digital platform, which are the highly knowledge-based platform in our great nation. I am Dr. Arul Raj. Most of you may know that I am the National President of Association of Physicians of India. I am a practicing acute medicine physician in my own institution, and we have been handling COVID cases in our nearby medical college, and I am the advising for the task force for the government of Tamil Nadu. I'll be too happy to share some of my current experiences with this COVID pandemic. A new name have been coined by me as COVIDology. And now, why you may all wonder, because this science is becoming so extensive, the disease is becoming so pandemic, and every day we get a lot of information about the genetic mutation, about its mode of entry into the body, and its dealing with our systems, and then clinical features, and then complications, and lot of treatment every day. One or other newer drugs are coming. Therefore, I thought I'll share some of my thought process with you all. That is why we are all here. I am sure I'll be able to convey some benefit to all of you on this science. Now, COVIDology, we always think that it could be a lethal pandemic. At the end of this communication, we will definitely arrive at a conclusion. Though the disease is of a very high incidence, the lethal nature is not that much. Therefore, we need not be worried about it. We need not have any fear, but we need to have only caution. Now, you may all wonder, how much is the incidence of this disease in our nation? As on yesterday night, it is about 5.25 lakhs of the population. And globally, now it has gone up very much, and the numbers are really going up. It has crossed about 10 million, that is 1 crore, 100 lakhs it has crossed. But if you see the data, the number of treated patients on treatment, and death rate, you just calculate. The death rate is very low. In my own state, Tamil Nadu, it's about 1.3, and India-wise, nationally, it is about 3%, and globally, it is about 4.9%. The incidence is high, numbers are high, but people coming out of it with good cure is high. People on treatment are high. That's what I wanted to convey you all. I think in the coming slide, we will see, what exactly things are going on. This is a study from WHO, which shows you the number globally is very high. But as far as India is concerned, per lakh of population, it is only 20. Whereas in other countries, it is about 746 and 589, 600, like that. India is fortunate on that. In the next slide, we'll definitely tell you that the mortality is also low in India. Mortality will also be low in India, and compared to the other countries. I think subsequently we may see that some more informations are available to us. See, these are the classical diagnostic clinical features. Clinical diagnostic features here. See, commonly you find a fever about 99% of cases, and some cold and some fatigues is seen, and the key symptom is loss of smell and loss of taste. If these two are there, we should always suspect in any patient with an upper respiratory tract infection, he or she may have a COVID. And loss of smell and loss of taste is very important. And there may be some cough, some throat pain, some muscle pain, or some even abdominal pain, some loose motions can be there. But most important thing is breathlessness. On seeing a patient, somebody having a dry cough with a throat pain and loss of smell and loss of taste, breathlessness. Clinically, you will vote for COVID. This is what I want to stress, because now we have opened up our clinics and we are seeing patients, and therefore we should know which patient to direct for a COVID examination. And in severe disease, daily, difficulty in walking, confusions, and some bluishness secondary of the face and lips, and even coughing out of blood secondary to some, thrombus, chest pain, and decreased white cells, and a renal fever, and a renal failure, high fever can be there. There are little on the severe side. Subsequently, I think we will see some more on this. Can I have the next slide? Yeah. This slide summarizes, this is from AIIMS. When you want to differentiate between a dry cough and an upper respiratory tract infection, only cough and a sneeze, it is air pollution. When there is cough, little mucus, and sneezing, running nose, it is common cold. And there is systemic features, you will have to suspect a flu. And a dry cough, a sneeze, high fever, as I told you, difficulty in breathing, you must vote for corona. This is the guidelines by AIIMS. Change the slide. Now the testing of it. See, you have made a clinical diagnosis. Now you need a laboratory confirmation. Yeah, we all know that RT-PCR is the, a very good diagnostic test, gives an accuracy of 66 to 88% sensitive. Average about 70% sensitivity and specificity are there. There are antigen kits, they have come. They are simpler and cheaper. Within few hours, you will get it. Within 1,000 rupees, you can get it done, but accuracy is not there. Antibody tests are also available, but here only issue is only after 14 days of the infection, we will be able to do that. And early stage of an infection, we may miss it, but it is highly sensitive and specificity is also high. I for the one who believe for NLR, that is neutrophil leukocyte ratio. There will be any infection, there will be a leukocytosis. Whereas in viral infections, there will be polymorpholeukocytosis or neutrophil, but lymphocytes are reduced. Lymphopenia. When the ratio between neutrophil and lymphocytes are reduced, are increased above 3.1, we always think at the back of the mind that the patient may have, a COVID. And a serum ferritin level, which is elevated at least 50%, should make us think that this patient has a virus or bacteria in his body. D-dimer in patients who are critically ill, patients who are, breathless, we should think that D-dimer, this patient, D-dimer is of high value, telling you that this patient has a thrombotic process which is going on. And when you try to triage, after that, having confirmed the disease, you will have to triage whether it is a mild form or a severe form or critical form. A mild form is without pneumonia or very mild pneumonia with something like a fever with a lower respiratory tract infection. There is no hypoxia in these patients. Whereas in severe disease, there is a dyspnea and the respiratory frequency is increased. There is a hyperventilation is there. Oxygen saturation comes down. Even on a FiO2 of 100%, it is coming down. And that says that this patient has got a severe disease. A critical disease is one. In addition to respiratory failure, they have a MOF, that is a multi-organ failure. Something like a septic shock or a cardiovascular disease or a renal problem or a hepatic problem. This occurs in about 5% of the cases. Next. See, this slide summarizes the pathogenesis or the mechanism of the occurrence of the complications of the COVID-19, as well as in which area we will be able to, intervene. This is the virus here. The virus enters through the nose, comes to the lung, and there are inflammasomes, and they have a cellular and humoral, immunity, T cells, everything is being affected. Endothelial dysfunction is there. Then it goes for cytokine storm, and there is a thromber formation. All our antivirals are acting here, and here all our plasma therapy is acting here. Some of our steroids are acting here, and ultimately we get into a multi-organ dysfunction. This is what it goes. Next. See, this is a triaging of the cases, and we have done it. Now, how to treat? There is a mild disease without hypoxia, no pneumonia, or no very little signs of a patch and hypoxia. For all these patients, we will have to monitor the pulse oximetry, D-dimer, but all these patients can be put on symptomatic therapy and observations. And we should give now, after seeing the, multiple complications, we are putting them on low dose anticoagulation in these people, usually with a low molecular weight heparin. We are giving 40 mg twice a day. Next. And when the clinical picture is on the moderate side, and again they are enrolled and all those things are there, here you will have to continue prophylactic dose of anticoagulation. If required oxygen, here comes the role of steroids, because the patient is entering into a little more deeper disease. Therefore, the drug of choice is dexamethasone. Commonly, we recommend about 8 milligram twice a day, and if the hypoxia is severe, we give 16 milligram twice a day. And now recently, the ICMR has recommended antivirals, that is a remdesivir, can always be utilized in these people. And we need to do other organ evaluation, whether there is cardiac, whether there is pulmonary. All those things have to be done at this stage. Something like a CT, angio, or a ventilation perfusion scan, and Doppler of the venous Doppler of the lower limbs to look for any deep venous thrombosis we need to do. Next, please. See, when there are very severe cases, continuous pulse oximeter has to be there. In addition to all these people, a therapeutic dose of anticoagulants, and something like 60 milligram. From 40, we go over to 60 milligram of anticoagulation, and we continue to evaluate the presence or absence of a thrombotic disease. Next. When there is a there is a critical case, up to heparin we have discussed about steroids, and then we have discussed about prophylactic anticoagulants and therapeutic anticoagulants, and we have talked about antiviral. Here we start ventilator support. Usually a high flow nasal oxygen is fine, but most of the patients may need a non-invasive ventilation. And suppose his hypoxemia goes refractory, we try to put the patient on prone position and try to recruit more alveoli. It's a refractory hypoxemia, then you try to recruit more alveoli. Even that is not working up, we need to put the patient on invasive ventilators. And sometimes if the hypoxemia becomes very severe, we may have to go for extracorporeal membrane oxygenator, what we call it ECMO, which has been well tried in the Western world, but least needed and tried in our country. Yes. Now, these are all the antivirals that have been evaluated. Favipiravir, we all know now it has come. And all these antivirals have under only not in the therapeutic range, they are only in the investigatory level. They have not been now permitted except our remdesivir. Recently. There is ivermectin, there is chloroquine, and lopinavir, ritonavir, all are there. They are still not recommended outside the clinical trials. Yes. These are again further lines of treatments. A convalescent plasma, though not routinely recommended, with the government permission, we are able to use it for very seriously affected patients. And a plasma exchange is also done. And as we discussed, steroids have to be given when there is a hypoxia, starting with or without ventilator support, and an immunomodulators, interleukin, antagonists, tosiclomib have to be used now. Again, it is an off-label, but it is being used in many centers with some legal, guidance. And vitamin C is definitely not indicated, though it is an off-label prescription, something like an immune enhancing, or it can reduce the fibrosis in the lung. These are all only, concepts, but they are not in the therapies. Yes. And when you continue the off-label therapy, this hydroxychloroquine or chloroquine plus or minus azithromycin is a common in any of the institutions. Any patient who gets in, they go for it. But as for the, as far as the trial goes, the trials do not find out any difference in the clearance of SARS, and and there is no quicker CT scan improvements and time of discharge, but still we are recommending it. Yes. Now there are non-randomized control studies, something like an observational studies, and they say there is an increase. Some of these cases have developed lot of resistant ventricular arrhythmia, and thereby they have caused an increased death due to, prolonged QT interval. And there are some cases in which the respiratory support has been well assisted by, hydroxychloroquine. Non-randomized study in France has recommended that nasopharyngeal PCR negativity comes much earlier in people who have used, chloroquine. Yes. Now to conclude about the chloroquine, though there are positive and negative, outcomes in RCT and non-RCT, clinically, without any evidence of a cardiac disease or follow-up the ECG of this patient, now the use of chloroquine has become a routine, not only in our country, throughout the world, and in some places it is of definitely used. But one place where it is definitely useful is, I'll come to it, later, that it is a pre-exposure prophylaxis. Coming to doxycycline, doxycycline has been proved to be very effective, and people with doxycycline and chloroquine, has been found to recover very well, and the death rate is supposed to be, very low by a study in New York. And vitamin C, there are no positive proofs, scientific proofs to utilize vitamin C. Yes. These are a few more antivirals, and now their combinations are also available. Now favipiravir is coming up very fast in our own country, but this has got also an equivocal results only. It has not proved, in a RCT, and it has an equivocal results only, not fully positive, but it is still, under evaluation, but it is recommended for the utilization. Yes. And again, same with lopinavir, ritonavir, all these things are still not, science has not recommended. Though a few small observational studies recommend that for want of a effective antiviral, they have been all used. Now this remdesivir has shown some positive, results. A faster median time to recovery has been found in an RCT. Therefore, now it has been recommended by ICMR and our Ministry of Health. Yes. A word about steroids. Steroids, now there are a lot of propagation that steroid is life-saving. Steroid is very, very useful, when used in adequate dosage in the right situation. That is, when there is a breathlessness, this should be the first drug. You can give it as a nebulization or as a systemic anti-inflammatory drug, dexamethasone, starting with 8 milligram twice a day or 16 milligram twice a day, has been with all our, antivirals that has to be used. And in ICU patients, the results have been really, wonderful. Yes. Now, anticoagulation, there are two ways of doing an anticoagulation. One is prophylactic, another is a therapeutic. Both I have discussed. Definitely, it is indicated. Whether if you are waiting for D-dimer results, also kindly start the patient. And this, toxilimab has shown significant improvements and definitely can be an adjunct therapy in cases of COVID-19 who are severe or critical. Yes. And convalescent plasma has been definitely found to be highly useful. 14 days after recovery, when you take out the plasma and give it to the very sick patient, they recover very well. 7 out of 10 patients have shown good improvement. And the plasma exchange has also been found to be very, very useful. About the vaccine, we are still lacking a definite vaccine, but there are now recent studies, only 2-3 days, a lot of things have come. We have worked up this MMR vaccine earlier, and now it is coming up. Whether it could be of use to these people, it will take time to give immunity, but still it is under trial. A lot of suggestions globally, even from India, we have given suggestions to ICMR that we should recommend to all the citizens of this world, everybody should have a BCG vaccine and a smallpox vaccine and an MMR vaccine. Now, having discuss about the current trends in the management, how to prevent. See, it is a disease which goes to about 10 to 15% to serious complications, and out of that, about 5 to 7% of them we lose. Therefore, prevention till today seems to be the key. The major things are only three: avoid a close contact, use sanitizer and try to use it. And then try to wash your hands and keep it clean, and also clean the areas which are being touched by human blood, like tabletop, and then the door locks, this and that. And as physicians are concerned, we should definitely see that we always clear our stethoscopes, ophthalmoscopes, and mobiles very well. Has to be clean, rather with the sanitization. Yes, as I told you, till today, social vaccine is the answer. Social vaccines has SMS, S for sanitation, M for mask, and S for social distancing. These are all the available prevention. As far as the vaccine status, there are a lot of vaccines are being tried: RNA, DNA, inactivated, and protein subunit, live attenuated. All are there. Others, this protein subunit has progressed well. I think in another 6 months' time, we will have an effective vaccine to, fight against this corona war. Yes. Now there is a recommendation by ICMR, chemoprophylaxis. That is what I told you earlier. We have also strongly recommended to the medical professionals and then our government of India that pre-exposure chemoprophylaxis with hydroxychloroquine, 400 milligram twice a day on day one and 400 milligram once a week, at least for 6 to 8 weeks, is very, very effective. In doctors, frontline healthcare workers, and frontline, police and other people, we need to use it. And how to reduce the number? Again, as I told you, precaution is better than critical treatment. If you don't prevent it, you may land up in a critical treatment. Therefore, always avoid a close contact. And the numbers are rising. You may all say that India had only 10,000, but today it has gone to, about 5.3 or 5.5 lakhs. The first principle is testing. Don't hesitate to test. Secondly, isolation, either in an institution or in your own place. Third is quarantine and contact tracing, and then containment, and then treatment. The key factor is social distancing, which our population is not able to, follow, and wearing the mask. Not simply wearing a mask, properly wearing the mask. Though there are for and against for, mask, but still it has to be done, at least for the healthcare people, and they properly covering the nose and mouth. All of them leave their nose, cover the mouth only and come. It is not of, complete usage. And see how the future of COVID will be there. Scientifically, there are three predictions. One is there can be recurrent small outbreaks like a flu and keep coming and going, or a monster wave can be there like a flu, like a plague. So many lives may go, or the crisis may continue to persist. But as per scientific evidences, a monster wave is unlikely, a persistent crisis is likely. Yes. Now, a word about health workers. See, our responsibility is to treat, see, examine, confirm, and treat the COVID patients at whatever stage they are. Therefore, the risk of health workers contracting COVID infection has been estimated by various levels, and it is about 33 to 45%. It was 33% 1 month ago. Now it is about 45%. There is a calculation also given. Yes. Yes. Next slide. There is also a calculation given depending upon, the age, diabetes, comorbid conditions. A ratio has been drawn. 10 points are there. If the points are between 0 to 3, it's a low risk. If it is moderate risk, if it is 6 to 7, if it is 8 to 10, high risk. Yes. For doctors also, this calculation triaging has to be done, and therefore we doctors try to be very, very careful of, taking care of your health. How can you take care? By avoiding a direct contact, using adequate PPTs, and take a chemoprophylaxis with chloroquine, and wherever possible, try to adopt telemedicine positively, which has been legalized by our Honorable Prime Minister as on date. Yes. And in an institution, patients are coming and going. We must minimize the chances of, exposure. Even before the patient arrives, must be taught he should come with cleaned hands. And upon arrival to the institution, there should be, a separation in the OP clinic and that is fever clinics and non-fever clinics. People going for fever clinics should get into the fever clinics, and all the people, all the healthcare persons must wear the protective, garments. Yes. Now, always the managing the facility is very, very important. The visitors' restriction and their guidance and training and blockades have to be given, and always they should be, made to wear the mask and wash their hands and then enter in. Yes. And you need to train and educate our own people also. We should report it to the health authorities, and very sick or ill, healthcare personnels, we should, take adequate care to treat them. Actually, APA has proposed that separate COVID hospital has to be there for doctors and healthcare professionals, and in many of the institutions, a healthcare wing or a COVID wing for the healthcare professionals we have recommended, and it is taking place in many places. Yes. And we need to adhere to the standard protocols as per the patient protection and placement and personal protection. These guidelines are very well given by ICMR and Ministry of Health in our country, and WHO and US FDA also giving guidelines, but let us follow our Indian guidelines. Yes. And COVID challenges. There is, I mean, you may say that many things are clear, but these are a few things that have come recently. Low dose hydroxychloroquine, 200 milligram twice a day, it has been proved by, I mean, ICMR, can be followed up, and and then there is a happy hypoxia. The patient goes on so well, even with a low, I mean, oxygen saturation with the up to 70%, and all of a sudden, suddenly, I mean, falls down dead. This is called as happy hypoxia, which has been found due to a vascular occlusion, sudden vascular occlusion, which we should be aware of. That is why, I mean, there are certain instances wherein, I mean, a pulse oximeter has to be provided rather than the digital temperature monitoring. You do with one hand a digital temperature, with the other hand you try to do, I mean, a pulse oximeter. That gives a better diagnosis and the level of the, I mean, disease. And scientifically, a lot of contributions have come. API has come out with the API and ICP guidelines on COVID. It is available to all the people, and a corona online course is available for doctors with CDC support. APA has developed it, and there are a lot of clinical trials which are going on. I mean, with ivermectin and doxycycline in, I mean, many cities with the, I mean, government permission, it is going on. We have got a lot of information from Monash University as well as the Bangladesh Medical College. A lot of things are there. And then coming to the, I mean, zero surveillance. I mean, as far as a COVID infection transmission is there, ICMR's day say that the number of populations are being affected are less. Lockdown and containment have been successful, and still large number of people are successful, I mean, susceptible, and risk is higher in the urban, and infection fatality rate is very, very low. Infections in containment zones may be high because we keep them, keep there many, I mean, infected people. These are the COVIDology conclusions, which our I endorse the views of Dr. Sashank Joshi, our endocrinologist and our Dean of Indian College of Physicians. When there is a loss of smell and taste with fever, and ideal case to go for a COVID testing confirmation. And a lymphocyte count very low, even if it is zero lymphocyte syndrome, we need to immediately start the patient on antivirals. Yes. And if CRP is more than 100, or I mean the oxygen saturations falls, I mean within 6 minutes of walking, methylprednisolone has to be given, and an inhaled steroid can also be given. And when there are muscle pains, anti-inflammatories can be used. Yes. Fever, if it is lasting for more than 14 days, you should think an extra cause. See, COVID never lasts more than 2 weeks. If there is a fever coming up in the third week, you should always think and suspect a coexisting infection. Sleeping 8 hours a day always reduces the disease incidence. And adding an atorvastatin 10 milligram and aspirin 75 milligram is definitely protective for people who are being discharged. And low molecular weight heparin is the standard of care. And now, ladies and gentlemen, execution is the key. You may all wonder how to control this possible. How? There are strategies available. There are people available. There are processes available. Execution is the key, wherein government, medical profession, and the public should come together. We'll be able to do that. No issue about it. Yes. Now, actionables. I mean, till we get a definite vaccine, non pharmacological interventions. Urban slums are highly vulnerable, and there the testing has to be more. Lockdown measures are highly useful. And high risk group of people, especially elderly people, people with chronic morbidities, pregnant women, children below 10 years, have to be definitely protected and taken care. Yes. Now the takeaway, I mean, message will be COVID is not lethal. I started my communication, COVIDology, lethal pandemic. Now I am closing it, it is not lethal. The death rate is too low in our country, globally also. And we should remove the stigma and the fear. See, there are a lot of ill effects are taking place for the COVID patients, which all of us know. That is because of the stigma. That should not be there. Yes, and doctors and healthcare professionals are lifesavers. We will win the corona war. I used to say there is a corona crisis. Together with the health professionals and the government, we will win over the war. Thank you, ladies and gentlemen.
Insights from the world's best medical minds. You are watching therightdoctors.com.